Our first speaker will be Emile Pothin. She joins us from the Department of Epidemiology and Public Health from Swiss TPH, and she will be speaking about the use of mapping and mathematical modeling to inform the optimization and impact of community health worker strategy in Haiti.
So thank you for the introduction. And before I start, I'd like to take the opportunity to thank the organizer of the symposium to have me speaking with you today and to present the work that I've been doing. So today I will be talking about how we use modeling to inform the impact of community health workers and to help programs to understand how they could be doing their planning for community health workers. So we all know that malaria is a curative disease, and one of the problems or the reason why we have a high remaining burden is because people do not have access to treatment, and most of the time it is linked to access to health facilities. So there is a community-based approach that can bridge the gaps in access, and then in this I'm being specific and I will talk about the community health workers and the deployment in an area of community health workers. But in context of budget restraint, then there's a need for more and more evidence to understand what is the impact of the deployment of the community health workers. So we use modeling to inform how this impacts, or how to simulate the impact of the deployment of each of the community health workers and understand how they would be the most impactful under operational constraints. So this methodology here will be used to determine where those community health workers need to be placed in priority, so understanding like their ranking in terms of priority. And I will show an example of how this is applied in Haiti and how we use it to prioritize the localities, so where they need to be recruited in Haiti. So I'll start. So the presentation will be in two parts. So first is about the methodology and understanding in a general aspect how we do it on an academic exercise, and then more understanding how it is useful when we take into consideration the needs from the program, how we've implemented this methodology. So to start with, to be able to inform any model, then we need to have data. So we work with the Malaria Atlas project to provide us some predicted maps. And I'll start here with an explanation of the map of the population density. So we have different sources of data for population, and we turn this into a predicted map. Here you will see, so the map of Grandance, which is the side of Haiti, is divided into pixels of 285 meters square. And for each of those, you might have areas where it's white on the map. It corresponds to where people do not live. So we just have information and predictions where we think people live based on census data. So we've got a prediction of where people live and the population. To this, we add the prediction of incidence. So that's coming from raw data based on surveillance data, THIS2 data, as well as prevalence survey data from the Malaria Zero Consortium. So to help us predict the incidence and understand where do we think the malaria cases are happening. And also, it's important to get an understanding of what do we think the access or the treatment rate is. And this we take the proxy of the access to care that is, again, a predicted layer that is informed by DHS data. So when we combine the three sources of data, they give us a predicted map of the number of untreated cases. And that helps us to understand what do we think the different gaps are in terms of where we would need to put those community health workers. So when we take this map and we have an understanding of the different gap, how it is distributed geographically, it's also important to understand how do we simulate, or how do we take into consideration the impact of those community health workers. So we take a few operational constraints into consideration. To start, we understand what do we think the community health workers can walk per day, or what is their catchment area. So we make the assumption that they can only catch around 2 kilometers around where they're located. Based on some preliminary studies, we assume that only 800 fevers, no matter whether it's malaria positive or not, malaria fever or not, only 800 fevers can be tested per year per community health workers. We also make the assumption that we think even if we place the community health workers, not everyone will go to these community health workers for other reasons than just proximity. So we assume that only 20% of them will never go to the community health workers and will never get treated. And the last assumption is also a key assumption, is to try to understand how many fevers we have. So how many non-malaria fevers do we also observe in communities? So we make the assumptions that what we observe in the health facilities, so based on the slide positivity rate, so that which is telling us in this part, in particular in Haiti, that only 20% of the fevers are related to malaria. So we make the same assumptions, that's what we find in the community. So then based on these assumptions, what we do is from this map that we have here, and for each of those pixels, we calculate how many fevers we would treat if we were to place a community health workers in those pixels. And then we come up with which of those pixels is the one that would give us the most impact, or the most fevers that could be treated. So that's how we placed the first community health workers and said this is where it should optimally be placed. And then iteratively, we then recalculate, so once we've put these community health workers, what's the impact of this? So what's the number of untreated fevers left? And there's less. And then we recalculate and say what is the next community health workers that we should be placing. And that gives us this algorithm, what I call an algorithm, which iteratively chooses the pixel and gives a ranking of where those community health workers should be placed in Haiti. And in fact, this algorithm then stops with the assumption that I gave it as an input and said it's only 80% of the fevers that can be treated. So the algorithm will stop and tell me how many community health workers, depending on the assumption that I give it to. And here it stopped when we achieved the treatment of 80% of the fevers that we have there. So the algorithm gives us then as an output the optimal placement, so the geolocation of where do we think community health workers should be positioned, only regarded to malaria impact at this stage, and also trying to understand how we rank them. If we don't have the budget to pay for everyone, is which one should we prioritize and pay for first. So the assumptions is the community health workers will increase the treatment rate. But we'll see that out of the 100% infection that we have, that corresponds to around 13 cases per 1,000 in this part of Haiti, then only 39% of them at the moment, so without the community health workers, would be treated would access care, sorry. So then we'll see that with this algorithm, the result of it is it's the line that we have, here, the dashed line. So it corresponds to, depending on the number of community health workers that you have, according to the ranking and the algorithm that I just shown, by how much do we increase the treatment rate, up to achieving around 80% as the algorithm was requested to stop at. So we'll see that we don't need to go up to 270 as the algorithm had suggested to have the most impact. We know that the last community health workers that we'll be placing will have limited impact. So we see that with 100 plus community health workers, if they're optimally placed, they would be sufficient to treat most of the cases that can be treated in this area. So, I don't know where I should be pointing. There you go. Sorry. So if I take the example of if we had only 100 community health workers, then to try to understand in terms of the resulting map, so how that has changed the access to treatment map, and understanding that maybe it hasn't reached everything to 80%, but overall, this is what we were asking. And then this kind of map, the resulting map, can inform the general access to care that people would have in those areas. We're assuming that treating cases is also changing the risk of infection. So the predicted risk of malaria will change. And then, so we go from the map that we had at the beginning of incidence, the predicted map of incidence. Underlying all of this methodology, then there's an estimation of the intrinsic risk of transmission, also called the R0. And that gives us then, when we put the community health workers, what's the impact of it, of treating people on the risk of infection, so on incidence here. And then this also helps to identify whether there's additional need for anti-malarial intervention. So then I'm just going to talk about what we've done in Haiti in particular. And because we talked to the program, we suggested this approach. So based on their request, originally we first had an exercise of theoretically how it would work, and then try to go a bit more into details and understand what are the needs. So first of all, the first criticism, if I can say it, is we work in terms of pixel, which is, okay, on a map that could be gridded, but in reality you cannot just force someone to live in a certain pixel. They live in a locality and they want to understand which locality they should be selected. So we had to work in terms of selection of localities and not of pixel. Also, the idea behind putting community health workers is to bridge the gap, especially of the individuals who are hard to reach, so far from the health facilities. So we try to understand how we can constrain the algorithm to just only work in areas where we think it's hard to access care. And then finally, it's something to keep in mind is here we're placing everything based on malaria impact, but community health workers work on more than just malaria. So understanding what is also the impact on beyond just treating malaria. So there's already a national plan for hiring community health workers in Grand Anse. And so the question was like, if we were to add additional resources in these hard to reach areas in 5 of the communes in Grand Anse, where should we be or which locality should be selected? So first we started to understand how do we define the hard-to-reach areas. So we work with the Malaria Atlas project to provide us a map of walking distance, so the walking distance from the health facilities, and then we sub-selected those for those 5 communities we're interested in, and then we looked at a buffer or a threshold saying if it's more than 1 hour, so according to the program needs, and said we need to have this threshold acceptable about 1 hour from the health facilities. So the blue areas that are highlighted here, so they intersect between the red area, the red circle or red shape, and the blue area corresponds to where we need to run the algorithm, and that corresponds to what we call the hard to reach areas. And also understand that there's a plan for community health workers already, so we need to account for the impact of the already placed community health workers. And then what we did is we run the methodology per pixel in the way that I have explained, but in those areas, and then we affected those pixels, the locality that were less than 2 kilometers away from so the center of the localities and the pixel recommended, so we chose localities with the closest distance as long as it was less than 2 kilometers away from this. So that gave them a plan of the number of community health workers that needed to anticipate in each of those communes and to try to help with the planning. So when we look also at the impact, as I showed before, on the left-hand side, it's the same map that we had, just restrained for the tip of malaria, so to have the 5 communes. And then we looked at if we were on the left-hand side with the current plan of the 77 community health workers deployed as it suggested, what would be the impact on malaria? And on the right-hand side is when we add those 20 community health workers, by how much does this map change? And we see that the area that is still in not blue, I would say, not in low incidence, corresponds to areas which is less than 1 hour, but they're not considered in the algorithm because they're not considered in the algorithm because it's less than 1 hour, but also they're not captured by the current plan because it's more than 2 kilometers away from the community health workers plan. So this also means that potentially it's highlighting where potentially there's still a gap for either additional community health workers or additional interventions in those areas. So that helps then to operationally to visualize the needs and the spatial distribution of where it would happen. So in terms of impact on access, so we looked at by how much, so this is aggregated result, we're looking at the proportion of individuals who would access care currently, so in those 5 communes. And then if we add the 77 community health workers, by how much is that changing the access to care? And then if we add on the top of this the 20 community health workers optimally placed this time, by how much we increase the treatment rate? And we see that it's not related to numbers in that case. It is really important just to make sure that we've got them optimally placed in the different localities where they would have the most impact. So this was mainly on malaria, and when we look at in those hard-to-reach areas, and we also looked at in this graph, I'm looking at the population, but also I want to highlight that in each of those 4 communes where we put community health workers, out of the 5 there was a commune there was no need for additional community health workers. But in the 4 communes where we have community health workers, to try to understand that there's a variability between the different communes in terms of the treatment rate that can be achieved. And this is only based on malaria. So we can see that there's still, of course, room for improvement in some of the commune, especially in Moron. But only looking at the impact that it would have, only looking at malaria to inform the placement of community health workers, there's already a good basis for bridging the gap in access. So here we've made all the methodology for access and making sure that people get treated and finding the gaps in spatially. Like the algorithm was important to prioritize where we need to emphasize access, but I think it's this sort of platform or methodology could also go beyond this and being imported into surveillance, for instance, and try to understand where we need to prioritize the proactive case detection, for instance. So in conclusion, what I think we've highlighted is the community health workers, we all know, will improve the treatment rate, but it's also important to understand that it will have an impact on malaria transmission as well. So what we've shown in this presentation is modeling provides a platform for understanding what would be an optimal number of community health workers, but as well as where do we think they should be prioritized spatially, so their geolocation, and in order to bridge this gap in access to health services, and then trying to account for operational constraints. So we made assumptions, so based on discussion that we had with programs, those assumptions can be changed depending on the questions or the setting that we might have, but at least we came up with a platform that could hopefully be helpful. We've made all these assumptions on the fact that we assume the people were not accessing care because of proximity, because of distance to the health facilities. But in reality, it's very likely that it's not the only reason, or it's not the main reason. So I think it's important to also understand the context and to be critical about like the output that we're providing to make sure that we've got appropriate responses for the placement of community health workers. So we've placed those community health workers, as I explained, based on the impact of malaria. But this could be already a good basis for more than just malaria, for all health needs. But at the same time, the methodology itself could be developed to include other data from other diseases if needed to make sure that we cover more than just malaria. So as I mentioned and just wanted to reiterate here, it's a platform for, could be a platform for integrated health services, but also for surveillance. So with this, I'd like to acknowledge the people that have highly contributed to this work. So my colleagues at CHAI, not sure what happened. I can just say because I know it. So I just want to acknowledge I would like to thank all my colleagues at CHAI and people based in Haiti as well as people I work with, my colleagues at Swiss TPH, the MAP team who helped me with the maps, the Malaria Zero program, Malaria Zero Consortium for their help in the interaction that we've had, as well as of course, the program manager, Dr. Lemoine in Haiti for all his very precious discussions. So thank you all.
We have time for any questions.
So since people are slow to the microphone, Emily, this is a bit far afield, but as I look at this, it makes me, so we're trying to improve people's access to health services, and we're doing it by putting people out there. Strikes me, I'm curious about your thoughts, that access may have to do with transport availability. Could you take this to the Ministry of Transportation and have the health ministry suggest to them that they build roads that would align with where you've got people far afield, and you could use your maps and your modeling to help them understand how to best build their roads in order to improve access to services, in addition to the work that you're doing with the community health workers?
It could be used. I think it would be more of a work for MAP to do this sort of thing, because they are the one building the map, and especially if you account for the transport, so the speed would be different, and then you need to account for other factors. It could be an advocacy piece that could be used for helping them, and then on the top of this, with the work that I'm doing. So rerunning the whole thing with different type of map, so your input would be different, and then your output would just have more impact, probably with maybe less people. You can achieve more if you had better roads. So it's a combination of both, but yes, I guess yes.
Hi, thank you for your excellent presentation. I had a question of whether you've considered incorporating drug stock into the model.
I haven't, because one of the big assumptions that I made here is I was assuming that access or treatment is completely linked with access. So if you put a community health workers, they would have the resources, they would treat people, and then there would not be any stock out at all. So then there's a lot of assumptions that I'm not accounting for is what if people don't go back every week or every time they plan to go and get their resources? So it's a complexity that could be added into the workflow, it's true, but like we need to work iteratively and first say, if everything, in the perfect world, if everything was working well, this is what you would be doing. In reality, it's trying to understand what is the context, but also trying to understand what data do we have to inform them.